Usually when we talk about a physical issue or like a medical diagnosis, there's this expectation of precision. It feels very much like engineering.
Right. Yeah, very cut and dry.
Exactly. Like if you break your arm, the X-ray shows that jagged white line, and the doctor just points at it and says, there is the problem, and here's the exact blueprint to fix it.
It's totally visible. The structural damage is right there on the screen, and the path to recovery is just a straightforward mechanical process of setting the bone and letting it heal.
But the moment you step into the world of chronic pelvic conditions, and especially when you try to navigate physical intimacy, that X-ray machine it kind of shatters.
Oh, absolutely. It is not straightforward at all.
Right. We're looking at a landscape that is undeniably murky. So today we are doing a deep dive into the medical realities of navigating intimacy with lichen sclerosus. We've got a stack of clinical guidelines, patient leaflets, and physiotherapy resources.
And our mission here is really specific.
Yeah. We want to show you how to short-circuit that painful trial and error process, right? We're looking for the exact sexual positions and physical mechanics that actually work.
Because to do that effectively, we have to look past the immediate surface anxiety. I mean, anyone dealing with LS already knows the structural baseline.
Yeah, let's briefly define that baseline for anyone who needs the refresher. It's a long-term skin disease, right? It makes the genital skin itchy, white, very delicate, and prone to tearing.
Exactly. The tissue loses a lot of its natural elasticity. But, and this is something the clinical texts always lead with, we have to reassure you on 3 crucial facts.
Right, the big 3.
Yes. LS is not an infection. It is not contagious, meaning you absolutely cannot pass it on through sex. And most importantly, it is definitely not cancer.
Which is such a massive relief to hear. But still, the daily reality of living in that fragile skin makes intimacy feel like you're, I don't know, navigating a minefield.
It really does. It completely changes the landscape of your sex life.
But the point we want to make today is that it doesn't have to end it. There is a very real evidence-based science to outmaneuvering those physical limitations.
There is. But before we can talk about the geometry of, which positions work best, we have to understand exactly what is happening to the body during sex when the tissue is compromised like that.
Right. So looking at these clinical guidelines, the core of the problem really boils down to the mechanics of friction.
Yes. The friction problem.
Because when you have LS, the normal penetrative friction that is usually totally harmless suddenly becomes this intense shear force on that structurally compromised skin.
And that sheer force is what causes the literal tearing of the tissue, which is awful.
Oh, it's brutal.
And those tears are not just painful in the moment. They trigger this prolonged recovery cycle where you have to use topical steroid treatments just to heal the skin barrier again.
Right. And experiencing that cycle even once makes people understandably terrified to attempt intimacy again. Why wouldn't you be?
Exactly. But the physiotherapy sources reveal this secondary internal reaction that I think a lot of people miss. It complicates the picture even further.
Okay, lay it on us.
So LS is primarily a condition of the external skin, right? The vulva. Yet so many people with LS report feeling this deep, intense internal pain in the vagina during penetration.
Wait, really? Because I found the physiotherapy notes really surprising here. If the inflammation and the delicate skin are mostly on the outside, feeling deep internal pain feels like a complete disconnect.
It seems like one, but the missing link between the external skin condition and that internal pain is actually the pelvic floor muscle group.
Oh, okay. So how does that work?
Well, the persistent chronic itching and pain of an LS flare-up creates this vicious feedback loop in your nervous system. The body registers the ongoing external discomfort, and as a protective, totally involuntary response, the pelvic floor muscles tighten up.
Oh, wow. So it's an involuntary guarding response.
Yes, exactly.
It's like when you know you're about to get a shot at the doctor's office and you tense your arm up. You're essentially bracing for impact to protect yourself.
That is a perfect analogy.
But flexing the muscle only makes the needle hurt significantly worse, right?
Right. The pelvic floor essentially goes into lockdown to shield the vulnerable vulvar tissue from further harm. But when those muscles clench, they form a rigid, unyielding wall.
So any attempt at penetration just meets this intense physical resistance.
Exactly. It meets the resistance from the muscles themselves, which fulfills the prophecy by causing severe internal pain. The muscles are literally fighting against the movement.
Which makes total sense why the clinical sources strongly advocate for pelvic floor physiotherapy. They don't just hand you a pamphlet and say, good luck.
No, not at all.
They teach you how to manually unlearn that guarding reflex using, like, targeted diaphragmatic breathing and internal trigger point release to coax your nervous system out of that defensive posture.
And there's another anatomical change we really have to factor into the mechanics here, which is clitoral fusion.
Right.
In some cases of LS, the chronic inflammation and scarring can cause the hood of the clitoris to adhere or just stick to the glands underneath. It essentially creates a physical barrier over the nerve endings.
But the clinical texts offer this massive neon flashing reassurance regarding fusion that we really have to highlight for you.
Yes, please do.
Even if the hood scars over, the physiological capacity to have an orgasm is still completely intact. The internal neural pathways are not erased at all.
Right. The hardware is still fully functional, even if the external casing has changed.
That's such good news.
It is. It might require shifting to different types of external vibration or exploring medical treatments to gently separate the tissue if the loss of sensation is severe, but the structural ability to experience climax remains completely possible.
Okay, so we have our physical hurdles, right?
Mm-hmm.
The sheer force friction on delicate skin and the involuntary tension of the pelvic floor. So the entire strategy for physical intimacy with LS is basically about engineering ways to bypass those two factors. And the clinical texts emphasize this golden rule for choosing sexual positions.
Yes, the golden rule. The person with LS must have total, non-negotiable control over 3 specific variables: depth, speed, and angle.
Dip, seat, and angle. Okay.
Because those 3 variables are essentially the steering wheel. If you control the depth, the speed, and the angle of entry, you dramatically lower the risk of friction-induced tearing.
Right.
And more importantly, holding that control gives your nervous system the psychological safety it needs. It tells the pelvic floor muscles to stand down and just relax. You know you can stop or adjust instantly, so the body doesn't have to brace for impact.
Which brings us to the top recommended position in the clinical literature, which is the receptive partner or the woman being on top.
Yes, highly recommend it.
Now, okay, let's unpack this a bit, because I get that being on top gives you that steering wheel we just talked about.
Yeah.
But biomechanically, does it actually reduce the physical pressure on the delicate vulval skin compared to other positions?
It absolutely does. Being on top completely eliminates downward compression.
Oh, I see. Because you're not pinned down.
Exactly.
Yeah.
You remove your partner's body weight from grinding against your sensitive external tissues. And furthermore, it unlocks this amazing ability to micro-navigate.
Wait, micro-navigate? How does that actually work in practice?
Well, say you have a specific raw patch or maybe a tiny fissure on the left side of your vulva from a recent flare-up.
Right, which happens all the time.
Being on top allows you to tilt your pelvis literally a millimeter to the right. You can minutely adjust the angle of penetration to completely bypass that inflamed spot.
Oh, wow. So you're literally maneuvering around the flare-ups in real time.
Yes. You simply cannot execute those tiny millimeter-level adjustments when you're pinned underneath someone's body weight.
That is a highly strategic way to maintain closeness without hitting the tripwires. I love that.
Me too. Now, the second highly recommended position is side lying, which is often just called spooning.
Right, spooning.
Spooning introduces this concept of neutral buoyancy to the pelvic region.
Neutral buoyancy. Because since both partners are resting on their sides, the downward pull of gravity is entirely removed from the equation.
Exactly. Without gravity pulling weight downward and without the direct, forceful friction of face-to-face contact, the sheer stress on that delicate vulval skin drops to almost zero.
Wow, almost zero.
Yeah, it's an exceptionally low-impact environment. Plus, the physical angle of spooning naturally limits the depth of penetration.
Which acts as a built-in safeguard against triggering that deep internal pelvic floor muscle pain we were discussing earlier.
You've got it.
But let's look at the reality of long-term relationships for a second. Because, as the physiotherapy leaflet notes, couples have routines, right?
Oh, definitely. We're creatures of habit.
What if you and your partner want to stick to the classics, like the traditional missionary position? We just established that lying flat on your back is super difficult because of gravity and direct pressure on the pelvis.
Right.
So how do you hack a position that is essentially structurally working against you?
Well, the physiotherapist suggests a really specific structural modification, and it just uses everyday items. You just place firm pillows under your lower back and bottom.
I was looking at the geometry of this pillow trick, and it's brilliant because it doesn't just elevate the body, it completely changes the angle of your pelvic tilt.
Yes, the tilt is everything.
By lifting the pelvis higher, And allowing the legs to be supported upward, you tilt the pelvic bone away from the direct downward force of your partner.
Exactly.
It seems like this shift in posture takes the structural pressure off the pelvic floor muscles entirely.
You are literally using geometry to bypass the mechanics of the pain.
Mhm.
By changing the tilt of the pelvis, the vaginal canal aligns differently with the angle of thrust.
That makes so much sense.
So the pelvic floor muscles no longer have to bear the brunt of the weight or the tension, which physically prevents them from locking up in that guarding reflex.
Amazing. But what if penetration of any kind is simply off the table? Like because the LS is in a really severe active flare-up.
That happens, and the medical texts are definitive on this point. Sex does not have to equal penetration.
Right. But couples still crave that specific physical closeness. They want the warmth and, the shared physical rhythm. So if a couple wants that closeness without the internal pain, how do the medical texts suggest they bridge that gap?
The pelvic health leaflets detail a highly effective workaround for this exact scenario. It's often referred to as intercurral sex or using the closed thighs.
Okay, so the receptive partner keeps their thighs pressed firmly together.
Right. And with generous lubrication applied to the thighs, while carefully avoiding the raw vulval skin entirely, of course, the penetrating partner moves between the closed thighs.
So it creates the sensation, the warmth, and the physical friction of penetration, but completely spares the vaginal entrance and the internal tissues.
It is a brilliant anatomical compromise. It provides the necessary physical stimulation for one partner while keeping the partner with LS in a completely pain-free, zero-pressure state.
And because the anxiety of internal pain is completely removed from the environment, it opens up the space for both partners to focus on other forms of intimacy.
Exactly, like breast stimulation or gentle, targeted clitoral touch, assuming that feels comfortable for them.
Okay, so even if you nail the geometry of these positions and you figure out the exact pelvic tilt, there's still a physical reality we have to solve,
The skin itself.
right? The baseline fragility of the skin.
Mm.
You can have the perfect angle, but if you don't prep the environment itself, friction will still win and cause damage.
And the clinical consensus here is clear. Anyone managing LS cannot rely on natural lubrication alone. The structural integrity of the skin just requires physical tools to buffer the friction and engineer a safe environment.
Yeah. And one piece of hardware mentioned in the specialist sources tackles the issue of depth control head-on. They're called O-nuts.
I love O-nuts. They are essentially a series of soft, stackable silicone bumper rings that are worn at the base of the penetrating partner's penis.
So they act as a physical, customizable buffer.
Exactly. Because, if you find that verbally communicating to reduce the depth of penetration in the heat of the moment is difficult, or if it just causes anxiety.
Which it often does.
Totally.
Yeah.
These rings physically stop penetration from going too deep.
It just takes all the mental math and the verbal guesswork right out of the equation.
It really does. The receptive partner doesn't have to lie there with their pelvic floor tensed up, anticipating a sudden, painful thrust because the physical hardware enforces the boundary. You outsource the depth control entirely to the tool.
That is so freeing. And then we have to talk about the liquid engineering.
Oh, the lubrication strategy. This is key.
Yeah, the urogenital and pelvic health sources outline a highly specific strategy called the double glide technique. It involves layering two entirely different chemical profiles of lubricant to maximize the protection of the skin.
Yes. Looking at the mechanics of the double glide, one partner applies a high-quality water-based lubricant, and the other applies an oil-based lubricant.
I'm guessing this is about utilizing the different properties of the liquids, right? Because the water-based lube acts like natural moisture to deeply hydrate the cellular tissue.
Exactly.
But because water-based lubes evaporate or get sticky over time due to their osmolality, the oil-based lube is added to act as like a sealant.
That is the exact mechanism at play. Oil does not absorb rapidly into the mucosa. It stays on the surface.
Right.
So you get the deep hydration from the water base locked in by the durable, incredibly slick, low-friction glide of the oil base. It creates an environment where the skin is protected by a really long-lasting barrier.
But we have a massive critical warning from the clinical sources that we absolutely have to pass on to you right now.
Yes, this is so important.
If you are utilizing the oil-based half of the double glide technique, you must be incredibly careful regarding barrier contraception. Oil-based products will absolutely annihilate latex condoms on contact.
They break down the latex structure almost instantly. It's a vital safety caveat.
Right. If you rely on latex condoms, you must stick purely to water-based or silicone-based lubricants. Do not mix them with oil.
Absolutely. Now, beyond the hardware and the liquids, the psychosexual counseling notes introduce a mental framework that addresses that anxiety feedback loop we discussed earlier.
The sensate focus technique, right?
Yes, sensate focus. It is a therapeutic technique, and it's crucial because chronic pain completely rewires how your brain perceives physical touch.
That makes total sense.
When months or even years of sexual encounters end in micro-tears or burning pain, the nervous system starts categorizing intimacy as a literal threat. Sensate focus is designed to untangle that threat response
Untangle it how? Like, how do you undo a neurological association like that?
by entirely stripping away the end goal. Sensate focus involves a structured period of time, often spanning weeks or even months, where partners agree to explore each other's bodies purely through touch.
Okay, so just touching.
But with a hard, non-negotiable rule, there's a complete ban on penetration and zero expectation to achieve arousal or climax.
Oh, wow. So you were taking the performance pressure completely off the table. It's no longer about reaching a finish line. It's just about feeling the sensation of touch.
Exactly. It usually starts with non-genital touch, slowly progressing to genital touch over time. And because the pressure to perform is gone, the nervous system slowly realizes it doesn't need to mount a defense.
So the pelvic floor learns to stay relaxed while the body is being held or stroked.
Right. And if any pain does occur, the exercise simply stops immediately. There are no feelings of failure or frustration from a ruined encounter because there was no goal to begin with.
Right. You can't fail if there's no finish line.
Exactly. Over time, the brain reassociates physical closeness with safety and comfort rather than anticipating a flare-up.
That is incredible. So pulling all these threads together for you, navigating intimacy with lichen sclerosus means you essentially have to draft an entirely new playbook.
You really do.
It's about actively modifying your angles. It's about using geometry to bypass gravity with strategic pillow placement.
Right.
It's claiming total, unapologetic control over the depth and speed of penetration, utilizing tools like bumper rings to enforce physical boundaries. And it requires engineering a friction-free environment with techniques like the double glide.
Because the overarching mandate from every single clinical text we looked at is that nobody should ever endure painful sex.
Period.
The structural damage to the tissue and the psychological pull of that anxiety loop are simply not worth it, especially when so many viable alternative paths to physical intimacy exist.
Which leads to a really interesting realization about what this diagnosis actually demands of a relationship. You just can't rely on your default habits or go on autopilot anymore.
No, you can't.
It forces a couple to communicate their physical needs, their boundaries, and their discomfort with absolute uncompromising clarity.
And that level of intense vulnerability raises a really provocative thought to leave you with today.
Oh, I like where this is going.
When a couple is forced by a medical condition like LS to dismantle their old routines and communicate with that kind of precision, they have to be truly present with one another.
Right.
So could it be that the necessity of navigating the physical hurdles of lichen sclerosus together might actually foster a more creative, more mindful, and ultimately more deeply connected, intimate life than they ever had prior to the diagnosis?
Wow. It connects right back to the idea of micronavigation we talked about with the physical positions, doesn't it?
Yeah.
You're maneuvering around the painful spots together, making real-time adjustments.
Exactly.
By communicating through the murkiness, vulnerability itself becomes the ultimate tool against the pain. You're forced to build a physical and emotional closeness that is completely custom fit to the realities of your bodies right now.
It is a very intentional, highly conscious kind of intimacy.
Well, we hope this deep dive brought you some clarity on the mechanics of what's happening under the surface, gave you a solid list of actionable strategies to modify your routines, and most importantly, the reassurance that you do have the tools to navigate this landscape.